Welcome to Oxygen Administration for Infants and Children. In 1774, as you know, Joseph Priestley was credited with discovering the colorless, odorless, tasteless gas that Antoine Lavoisier 1 year later would name oxygen. Nearly 150 years would pass before a Finnish pediatrician, Arvo Jeppo, recommended the intragastric administration of this gas to infants. But it wasn't until 1934 that a very clever Dr. Julius Heff, chief of pediatrics at a hospital in Chicago, first used an inhaled oxygen delivery device for pediatric infants. His oxygen box, pictured here, consisted of a metal hood with a small window, and it was the first oxygen chamber used within an incubator. Although the device was criticized for making it difficult to see the infant and work with it, and for its inability to maintain high oxygen concentrations, it led to the development of oxygen administration devices for infants and children. These played an essential role in the administration of oxygen. Laboratory data used to assess hypoxemia. Some of the tests used to assess hypoxemia include arterial blood gas results, or tension of arterial oxygen, P-AO2, oxygen saturation taken on pulse oximetry, or saturation of oxygen. Increased levels of lactic acidosis may also indicate tissue hypoxia. So let's talk a little bit about what causes hypoxia and hypoxemia. Hypoxemia can be a result of decreased alveolar ventilation, decreased oxygen in the air inhaled, poor ventilation-perfusion relationships, intrapulmonary or cardiac shunting, diffusion deficits, or not having enough red blood cells. I want to elaborate a little bit on a few of these conditions. Decreased oxygen of inspired air means that I don't have enough FiO2 in the air that I'm breathing. This can lead to hypoxemia. Hypoventilation is not taking a deep enough breath. Diffusion abnormalities can happen when there's a blood clot. Abnormal ventilation to perfusion ratio may happen in cases where the alveoli are full of fluids, such as pneumonia. Pulmonary right-to-left shunting happens in cases of atelectasis and acute rest syndrome. Measurement of oxygen tension and saturation. In children, a PaO2 of less than 80 millimeters of mercury and an SpO2 of less than 95% usually indicate hypoxemia and warrant watching and caution. And in the case of some specific disease processes, may even warrant treatment. However, it is generally agreed upon to only treat an SpO2 of less than 90% or an PaO2 of less than 60 millimeters of mercury, because fetal hemoglobin hemoglobin has a much greater affinity for oxygen. The oxygen dissociation curve is shifted to the left, allowing for higher saturation of any given PaO2. For this reason, it is generally agreed upon that a PaO2 of less than 50 millimeters of mercury and an SpO2 of less than 88% in a neonate indicate hypoxemia and require the initiation of oxygen. The PaO2 and the SpO2 are principal clinical indicators used to begin, monitor, adjust, and terminate oxygen therapy. So what are some of the signs and symptoms that we see in cases of hypoxemia in children? One of the first signs is tachycardia and tachypnea. As time goes on, the child, if untreated, the child will develop decreased ventilation or hypoventilation, apnea, bradycardia, and cyanosis. However, I warn you that cyanosis is a late sign. We'll talk more about it. Symptoms include restlessness, anxiety, tachycardia, tachypnea, bradycardia as a late sign, extreme restlessness, and severe dyspnea. In pediatrics, we also, since small children can't always tell us what they're feeling, we also consider feeding difficulty, inspiratory stridor, nasal flaring, expiratory grunting, and sternal retractions. An easy mnemonic to remember is early, RAT for early signs, is late to bed. Bed being bradycardia, extreme restlessness, and dyspnea. And if he's late to bed, he will get a fine. Feeding difficulty, inspiratory stridor, nasal flaring, expiratory grunting, and sternal retractions. So, you need to use caution when looking at cyanosis, central cyanosis in infants. It may be present when there are 5 grams of desaturated hemoglobin. However, in cases of severe anemia, you may never see cyanosis, and in cases of polycythemia, hypoxemia may be absent, but the patient may look cyanotic. So please use caution when relying on a patient to look blue. Late signs and symptoms of hypoxemia, remember, involve confusion, lethargy, or coma. Complications of oxygen administration include hypoventilation, retinopathy of prematurity or ROP, atelectasis from nitrogen washout, pulmonary vasodilation, and pulmonary fibrosis. These are separated into 2 categories: adverse physiologic effects and equipment-related complications. We'll discuss the adverse effects from specific oxygen devices later. But let's talk about first physiologic concerns. The role of oxygen delivery in the development of retinopathy of prematurity is clear. Hyperoxia and loss of maternal-fetal interaction is believed to cause suppression of growth factors and constriction of the retinal and cerebral vessels in premature infants. This can lead to ischemia and varying degrees of retinal scarring and retinal detachment. ROP may resolve spontaneously or result in permanent visual impairment, including blindness. Many factors in addition to oxygen appear to correlate with the development of ROP, including gestational age, swings in oxygenation, intraventricular hemorrhage, and swings in blood pressure, sepsis, and low birth weight. Current practice supports oxygen therapy targeting SpO2 levels of 88 to 95% and maintaining a pAO2 of 50 to 80 millimeters of mercury in premature neonates. And ROP. Atelectasis can happen from nitrogen washing out of the alveolus. High concentrations of oxygen have been linked to atelectasis, pulmonary vasodilation, and pulmonary fibrosis. When you have high oxygen levels, the alveolar tension of oxygen may increase, nitrogen may decrease, resulting in absorption atelectasis, as discussed. As the nitrogen is replaced by oxygen, the blood rapidly absorbs the oxygen and the gas volume decreases and atelectasis develops. High FiO2 levels may also result in pulmonary vasodilation. As the pulmonary vasculature dilates and alveolar volumes decrease, areas of VQ mismatch occur, and increased intrapulmonary shunting and worsening of the arterial oxygen delivery may develop. In pediatric patients with cardiac insufficiencies, such as hypoplastic left ventricular or a single ventricle, the increase in pAO2 that occurs with oxygen therapy may compromise the balance between the pulmonary and systemic blood flow. There are also reports of pulmonary fibrosis occurring after oxygen administration to patients with paraquat poisoning and those receiving chemotherapy. Caution needs to be exercised. Symptoms of too much oxygen include visual loss, nearsightedness, cataract formation, bleeding and fibrosis of the eyes or retina, seizures, and jerky breathing, irritation, or coughing. The cycle of oxygen toxicity can be insidious. You have an infant with a low pAO2, so you increase the fraction of inspired oxygen given to the infant or child. This creates oxygen toxicity if not watched carefully. Then there's increased shunting, and you have a low pAO2 again. And the cycle persists. You'll increase the FiO2, oxygen toxicity develops, and then increase shunting, which calls for making sure that your SpO2s and your pAO2s are between 88 to 95% for SpO2 and 50 to 80 for pAO2 to avoid this cycle. Specific clinical conditions where this may not be the case are myocardial infarction, generally in the ED, and myocardial infarction isn't common, but it does happen, especially with some teenagers. Generally, we'll give them 100% oxygen, especially in the emergency department. However, we want to make sure that we get a blood gas and follow recent research that shows high FiO2 may actually lead to vasoconstriction of the coronary arteries and contribute to cardiac ischemia. Let's talk about the two classifications of oxygen therapy equipment, and this should be a review for most of you. There are low flow or variable performance devices, including devices with reservoirs, and fixed performance or high flow systems. Let's talk about variable performance or low flow devices first, and we'll start with the most commonly used in neonates, infant, and children, the nasal cannula. It's a small soft tube with two soft prongs that's hooked to 100% FiO2 gas source or flow meter. From the flow meter, generally in pediatrics, we always use a bubble humidifier. Flow rates can vary between half a liter and 6 liters per minute, depending on the age and size of the child. FiO2 range varies as well, from 22 to 44%. We'll look at that more closely in a minute. There are also low flow and microflow meters available for infants and neonates needing oxygen. The nasal cannula is contraindicated for nasal obstructions such as choanal atresia or facial trauma. Estimating FiO2 when using a nasal cannula. 1 liter, 24%, 2 liters, 28%, 3 liters, 32%. As you can see, I gain about 4% each time I increase my liter flow. As compared to oxygen flow rate and approximate FiO2 in a simple mask. From 5 to 6 liters, about 40%, 6 to 7 liters, about 50%, and 7 to 8 liters per minute, about 60%. Simple masks have a flow rate range of 5 to 10 liters per minute, and they must be at least 5 liters per minute to wash out CO2 that accumulates in the mask. A simple mask, partial, however, compared to reservoir mask, partial or non-rebreathing masks, these are indicated for some infants and older children, but not really indicated for neonates. First, we'll talk about the simple mask. The simple mask is a lightweight plastic reservoir designed to fit over a patient's nose and mouth, and it's secured with an elastic strap around the patient's head. Open ports on both sides of the mask allow for exhalation and also allow the patient to draw in room air during inspiration. FiO2 varies with a patient's inspiratory flow and the oxygen flow into the mask. Room air is entrained through the exhalation ports in the mask if the patient's inspiratory flow rate exceeds the oxygen flow rate. Flow rates from 6 to 10 liters per minute provide a variable FiO2 depending on how deep of a breath the patient takes. This FiO2 can be anywhere from 35 to 50%. However, there is absolutely no data concerning newborns and infants to predict effective FiO2. Contraindications are that a simple mask is reserved for infants and children who need moderate concentrations of supplemental oxygen for very short periods, such as medical transport, emergency stabilization, and post-anesthesia. Oxygen concentrations may be higher in patients with very small tidal volumes, and therefore simple masks aren't suitable for infants or small children who require low or precise concentrations of oxygen. The partial rebreathing mask. In the partial rebreathing mask, there are no one-way valves. There is a bag hanging from the end of the mask, and other than having no one-way valve over the top of the mask, it looks identical to a non-rebreathing mask. Here is a non-rebreathing mask. As you can see, there are valves, one-way valves, at the arrows. Notice that one of the one-way valves is missing. That's a safety feature. Reservoir masks, such as the partial and non-rebreathing mask, consist of a soft, lightweight material with a plastic reservoir bag attached to the front. Oxygen source gas flows directly into the neck of the mask and is directed into the bag during exhalation. When a patient inhales, high concentrations of oxygen can be delivered from the bag through the mask. Currently, there are two types of reservoir mask: partial rebreathing and non-rebreathing. The non-rebreathing is similar in design to the partial rebreathing mask, but has one-way valves that function to keep the patient from rebreathing any exhaled gas. A one-way valve located between the face mask and the reservoir bag allows 100% source gas to enter the mask during inspiration, but unlike the partial rebreathing mask, it prevents any of the patient's exhaled gas from entering the bag. This is used primarily in emergencies and for short-term administration of high concentrations of oxygen. I have a question for you. Look at the picture, the small child pictured here. Is this a partial or a non-rebreathing mask in the picture? How can you tell? This is a non-rebreathing mask. As you can see, there's a one-way valve between the mask and the bag. Now we'll move on to fixed performance oxygen delivery systems. These include the air entrainment mask, the air entrainment nebulizer or large volume nebulizer, high humidity, high flow nasal cannulas, and enclosure devices such as the oxyhood. First, we'll talk about air entrainment devices. There are two kinds. There is an air entrainment mask, commonly known as a Venturi mask, pictured here, and air entrainment nebulizers, such as a large volume nebulizer. Air entrainment mask or Venturi mask are example of a high-flow system that provide the patient's entire inspiratory requirements while delivering a predicted and precise amount of oxygen. This is accomplished by providing the total flow of gas that exceeds the patient's ventilatory demand and thus eliminates dilution of oxygen concentration with room air, such as occurs in low-flow devices. The performance of the mask, a Venturi mask, is based on Bernoulli's principle. As 100% oxygen under pressure flows through a small jet orifice entering the mask, velocity increases, creating viscous shearing, and as a result, room air is entrained through the open ports located at the base of the reservoir mask tube attached to the front of the mask. By varying either the diameter of the jet orifice or the size of the entrainment ports, the amount of room air entrained can be proportionally changed, resulting in higher total flows and specific concentrations of oxygen delivered to the patient. Air entrainment mask is indicated for older patients who require a controlled FiO2 either at low or moderate levels. Commercially available masks capable of providing oxygen concentrations that range between 24 to 50% in a hypoxic child with increased respiratory rates and tidal volumes. The air entrainment mask is a preferred oxygen delivery system. For pediatric patients with chronic carbon dioxide retention, the air entrainment mask is ideal because it maintains a constant FiO2 even at low concentrations, such as 24%. The air entrainment nebulizer, or large volume nebulizer, is an all-purpose nebulizer that has particulate water and contains adjustable air entrainment ports to control the oxygen concentration. The addition of heat gives this type of system the advantage of providing 100% body humidity when clinically indicated, as in the case of a tracheostomy on a child. Air entrainment nebulizers are used when high levels of humidity or aerosol are desired. Patient application devices used with the nebulizer include a tracheostomy collar, face tent, or aerosol mask. Hazards and complications include cold stress for neonates in the case of a non-heated nebulizer, and it's difficult to keep in place and may even create agitation. The next fixed performance device we'll talk about is the high humidity, high flow nasal cannula. High humidity nasal cannulas deliver moderate to high FiO2 values and provide a cost-effective alternative for patients who require a high level of oxygen concentration. Oxygen delivery with a high-flow nasal cannula is most often indicated for use in patients with hypoxemia who have not responded to oxygen administered with a low-flow nasal cannula. It may also be indicated for use in infants and children with lung disorders who require improved oxygenation or a reduced work in breathing. The high-flow cannula has also been recommended for infants in the management of apnea of prematurity. It is a less intrusive measure to deliver high flows of oxygen. Its use may reduce the potential risk of iatrogenic injuries associated with nasal continuous positive airway pressure and machine ventilation. However, contraindications for the use of the high-flow nasal cannula may include suspected or confirmed pneumothorax, severe upper airway obstruction, and absence of spontaneous ventilation. Most systems offer several cannula sizes, including premature, neonate, infant, intermediate infant, pediatric, and adult. The cannula that is most appropriate size for the patient should be selected, making sure the prongs do not occlude the patient's nares. The high-flow nasal cannula is attached to the patient in the same manner one would attach a low-flow cannula. The oxygen concentration is adjusted with the blender, and the flow rate is adjusted with the flow meter, set typically at the lowest flow range for age. Modern enclosures include oxygen hoods. Oxygen hoods are transparent enclosures constructed of a clear plastic material in a cylinder or box-like design. They are rarely used currently. Oxygen can be administered through large bore corrugated tubing attached to the hood, and the hood surrounds an infant or child's head, leaving the body accessible for nursing care. This design allows the infant to be placed in a neutral thermal environment, such as an incubator, and still receive controlled oxygen concentration. The oxygen is delivered to the hood with heated humidification by means of an oxygen blender or dual air and oxygen flow meters, or a heated air entrainment nebulizer. When using the heated air entrainment nebulizer, the nebulizer is powered with compressed air, setting the oxygen concentration dial at 100% and bleeding oxygen into the nebulizer. In this way, oxygen concentrations are more easily regulated and noise levels are reduced. This is the end of this talk. Thank you for your time and attention. Have a great day.